scientists in the United Kingdom. And so they found that there are similarities that they've detected at that level. As we all know that in the UK, they'd actually even gone to report to their parliament. And at this point, we believe it's very important that we share this research finding to all South Africans. We have briefed the president and some of the health stakeholders, and we will be going on to brief the rest of the cabinet and the members of the National Coronavirus Command Council. So at this point, I would like to invite my colleague, Minister Mkhize, Minister for Higher Education, Science and Innovation, because these two departments collaborate on the support that is given to the institutions that are doing this work. And at this point, therefore, would like to invite my colleague, Minister Nzimande, to make some opening remarks. At the end of the presentation, Minister Nzimande will also make comments looking at way forward. I will also do the same, responding to the issues that would have been put on the table, just to give you a sense of what is our attitude as the Department of Health when it comes to dealing with the findings from the research. Thank you very much. My colleague, Mpepete, please take the floor.
Thank you very much, Minister Mkhize, our Minister of Health, and the Deputy Minister, Joe Pasha, the members of the Ministerial Advisory Committee for Minister Mkhize, as well as Tulio, who is the Director of CRISP. Thank you very much for this opportunity, Minister Mkhize. All really that I wanted to say is to point out that this is one example of the whole of government approach and cooperation. As the Department of Science and Innovation, we have been very much part of this project through our Strategic Health Innovation Partnership, which has funded CRISP for this project on spatial and genomic monitoring of COVID-19 cases in South Africa, which was initially funded by 10 million rands. We're very pleased to see that there is actually products in terms of the spatial and genomic monitoring of COVID-19, and also the important role that we are playing to support your effort, Minister Mkhize, and that of all of government, with scientific backup in terms of engaging and understanding this pandemic better. I don't need to say much, of course. CRISP was established in 2017 and is situated at the University of Natal, KwaZulu-Natal's Nelson Mandela School of Medicine, and is a cutting-edge genomics center which offers a range of DNA sequencing, precision medicine testing, bioinformatics services and technologies to academic, industrial, and commercial users. And of course, in this instance, the work that they are doing is going to be of enormous assistance to the National Coronavirus Command Council and in the work of the Department of Health in dealing with COVID-19. So on our side, we're fully supportive of this initiative. And thank you very much, Minister Mkhize, for being part of this press briefing.
Thank you very much. We're going to request Professor Abdul Karim to start the presentation. He is also going to invite and introduce the whole team, and then we'll come back at the end. Thank you very much, Prof. If you can go ahead.
Thank you very much, Minister Nzimande and Minister Mkhize. It's a great honor to have this opportunity to share with you some new scientific research findings. I'm afraid we do not have good news for you, but we want to present the news in a way that enables you to understand what we are now seeing in the second wave. So the way we've structured this is that Professor De Oliveira will start with a presentation that will share with you what we are looking at in the phylogenetics of the virus. I will do a short presentation thereafter, and then I'll hand back to Minister Mkhize. Without further ado, I'd like to call on Professor De Oliveira, who is the Director of the KwaZulu-Natal Sequencing Innovation platform, who will do his presentation, sharing with you the latest results from the viruses that have been sequenced from various clinics on COVID-19. Over to you, Tulio.
Thank you, Professor Karim. Thank you, ministers. So I will start a short presentation. We drove this presentation to, despite being very scientific, we think that's going to be understandable by most of people in the country. So just to start, the title of the presentation is Emergence and Very Rapid Spread of a New SARS-CoV-2 Lineage with Multiple Spike Mutations in South Africa. As both ministers and Professor Karim has presented, my name is Tulio de Oliveira, and here I'm presenting results not just from CRISP, the research center that I direct at the University of KwaZulu-Natal, but from a bigger consortium in the country. So just to start, genomics has been a very potent tool in the fight against COVID-19. It was used to discover the virus that caused the disease, and that was very quick. Within 15 days of identifying an unusual case of pneumonia, they could identify the virus that was very similar to SARS. That's why they call SARS-CoV-2. It was also used to develop our diagnostic, this means our qPCR, the tests that people do. So basically what this test does, it is to look for probes in the genes of the virus. It was also used to develop vaccines. All the vaccines that we are currently in development and the ones that have been approved, both the mRNA and the vector vaccines, will use the genome of the virus. We really also use genomics to understand transmission, to see where the virus comes from. Also very important to control outbreaks, has been showing a very good tool, and to understand the spread of the virus in the country. It is also through this technology that we identify reinfection and understand how our body, how the host, the human host, interact with the virus. So this is a very big international program that have produced over 250,000 genomes, which 2.5 of them here in South Africa. How we set up this program, it is to do that in real time. What it means, that we could keep surveying the virus in the country as it happens, not as an academic exercise that you look at which virus caused the infection 6 months later. So what we did, we partnered, very close partnership with the National Health Laboratory Service, the NHLS, the NICD, and then what we did is to put one genomic center close to each of the labs. This means here in Durban, we do it in Albert Latulle Central Hospital, and then in the University of the Free State, also with the NHLS based in the Pelonom Hospital, in the same with the Tygerberg and the UCT. And this allows us to really sample widely in the country, but more important, very quick. If it just to ground you in this information here, on graphic panel number A, we have what you call our number of cases, or what you call first wave, and here, the most important information here is these little blue dots. So these mean the genomes that we have sequenced from the virus. And we went back to the contact of the first individual, and we keep surveying that during all the first wave, What we learned from the first wave, it's where the virus came from to South Africa. The majority was introductions was from Europe. That's not surprising, given that 80% of our international air traffic outside the continent is to Europe. But what's happened is that after the introductions that now is just shown in these little black dots, it starts spreading widely in the country. So we know that like more than 99.9% of the infections in South Africa were spreading inside the country by strains that have been introduced from outside. So just also to understand that, just what I'm showing here in this axis is the dates where the samples were collected. In the y-axis is the proportion of the genomes that identify into a given lineage. What it means that normally when I have white here, I have too many lineages, too many viruses circulating and not one dominating. Yeah. So we have normally dozens of lineages circulating one time. And then what will happen during our lockdown, we start establishing what you call specific South African lineages. And they get name in the classification. That's the international classification of SARS-CoV-2. And what we found over time is that these lineages or this virus, it was infecting around like 10, 15% of the population of individuals with these three main lineages. Yeah. But what we found very recently, and that's why we are here sharing this information with you, is that as we pass our first wave, yeah, some of the main lineages start circulating, and then we have the appearance of this new lineage of the virus that very quick start dominating all the genomes that we sample. What it means that when we look for the virus now, we have not finding the lineages, sometimes dozens of them or the main lineage, but now we are finding one lineage that is starting to move around the second wave with around 90% of the sequence being dominated by this single lineage. Yeah. So what we do with that data, it allows us to understand with the genomic data, what we call phylogenetics, yeah, the origin of that, which means where it seems to have started, yeah. Not surprising, it started close to where our second wave of the infection started. This is in the Eastern Cape, close to the Nelson Mandela Bay. It's very important to know that we don't know where this virus, this lineage was created. We know where it starts spreading at a very fast pace is in the Nelson Mandela Bay. And these colors here represent when the introduction happened to other areas. So if there is light blue, that was early. When we say early, that's around July, August, September in the year. And the dark colors is more recently around October, November, and December. So this lineage starts spreading first in the surrounding areas. It moved to the garden route, and most of you are going to be aware of the size of the second wave in the garden route, and then started spreading also to KwaZulu-Natal. We have, so basically following the coast. In KwaZulu-Natal now we have 7 of the 11 districts. We find that lineage, and also to Cape Town. So we have generated from this lineage only close to 200 genomes. To be honest, we generate a little bit more in the last few days, yeah. And they sample from the 15th of October to the 25th of November. And they come from over 50 clinics. So we are quite confident that our sampling has been quite random. And that's where the partnership with the NHLS is so important, because they are the ones that select the random samples to be sequenced, yeah. One thing that we find, of course, we focus a lot in this area on the second wave because that started. Once entering in Cape Town, and that's just data that we're analyzing at the moment from the Tygerberg, from the Stellenbosch University, it seemed to also dominate in Cape Town to close to 88% of the sequence in the Western Cape and around the coast also being of that lineage, yeah. So that is concerning how one lineage dominating this pandemic in the second wave. Just to ground you here, I have the 3 previous lineages of SARS-CoV-2 that circulate in South Africa. They have a number of mutations to the genome, the original genome that was identified in Wuhan, China. And this new one has more mutations, have like between 20 and 25 mutations. But what is striking, it is all these mutations, they cause amino acid changes in the proteins. What it means that seems that they have a functional difference, making the virus behaving slightly different. So what we do next is to identify which proteins this virus is changing. And again, to ground you, that's the first lineages, the main lineage circulating the first wave. They have 1 or 2 mutations in the key protein of the virus, and I'm going to give you more information, but they translate to only 1 amino acid mutation. And that's amino acid mutation that has been emerged in Europe and have shown the virus to be more transmissible. This new lineage has 7 or 8 mutations, and all of them change the amino acid. And then what we go after is to see what's the effect of this change on what you call the CT score. The CT score is a technical term that comes from the testing, the testing that people do in the nasopharyngeal swab. And as low is the CT score, it's associated with a higher number of level in the individual. So this lineage seems to have lower CT score, suggesting that maybe has circulating at a higher level in an infected individual. So just to explain to you what is the importance of the back of this lineage and where the changes happen in the protein. Here we have the virus. The virus, it will use a protein that's called a spike protein. So basically they call it spike because outside the cell, it will bind to the human receptor cell to enter in the body. So that's how the virus set infection, yeah? So not only this spike protein has 8 substitutions, but what we normally worry is where they are. And in the case, they are in the region called the receptor binding domain. And this is the main domain of the virus that the neutralizing antibodies will attack. This means how the body clears the infection and also the focus of the vaccines. So mutations there may therefore affect the binding or neutralization of the virus by individuals, yeah? If we get a close look at the virus, and here's the virus, what is called the protein 3-dimensional structure, that's the domain of the virus of the spike that bind to the human receptor. Here's the human receptor, the ACE2 in gray. We have changes in 3 key amino acids. Yeah, the first one is the 501Y, which seems to enhance the binding affinity of this virus to the receptor in the body to enter the cell. And that's exactly the same amino acid mutation that have been identified in the UK last week, which seems to also be associated with a fast spread of a lineage, yeah? And they end up locking down the whole London to try to curb this transmission, yeah? But this virus also have 2 other substitutions, 2 key residues that also bind in the human protein, and that it is also probably enhancing the binding affinity, but also associated with resistance to the natural antibodies of the body. Yeah? I know that this sounds a little bit too scientific for the public, and that's why Professor Slim Abdul Karim will follow, which see what's the implications to of this change, yeah. So what's the next steps? What the scientific community is trying to understand very quick in South Africa, but also international, yeah. You try to get a better understanding where there is any clinical epidemiological evidence to suggest phenotypic impact. A phenotypic impact, it means that this virus is behaving differently, yeah. The first big question that we're trying to answer, if it is increased transmissibility, it needs to be confirmed, but it's very plausible or very likely from our data that this increased transmissibility, both from one strain dominating more virus and the protein changing, potentially entering it easy in the body, does increase pathogenicity. We don't know, but the main evidence point, no, this virus should not be more pathogenic than the other one. Of course, if you have a lot of more transmission, we're gonna have a lot of more sick people just in the numbers, and we have to be really careful to not overwhelm our health system, yeah? And the next big question, it is the escape from neutralizing antibodies to see if this virus could reinfect individuals. The evidence points to potentially no, but we have to do that and understand that very quick. And Professor Abdul Karim will point to that. At the same time that we are doing the genomic surveillance, we are also growing the virus in the laboratory. That's done with some of our colleagues at just in the same building. Just to be aware, CRISP is in the same building as Caprisa, that Professor Abdul Karim is the director. And then we have a third center called the Africa Health Research Institute. And we work with a professor there, Alex Siegel, to grow the virus to see if infect more in a cell system, but also to see how neutralizing antibodies would affect this virus. Yeah. So We need to strengthen genomic surveillance, what it means. We need to increase the sampling in the main areas that are being affected by the second wave, yeah, but also to other provinces. And we're working very close with the NICD, the UCT, Stellenbosch, and the group, and the University of the Free State to understand if this virus is already found in the province, yeah. And we also have to link very quick with clinical investigation of cases of suspected reinfection or more severe development. So just to conclude, genomic surveillance is a critical component of the public health response. It has been widely used and very effectively in the countries that control very well this pandemic, such as China, Singapore, Australia, New Zealand. The UK also use a lot of genomic surveillance. And here in South Africa, we have the chance to use that from the beginning. And we think that early identifying that this strain is very important. We have detectable a new lineage with change at key sites at the spike glycan proteins, which show evidence of rapid and diffuse spread through 3 provinces. We are now trying to get information of the other ones, but we are not surprised if it already has spread through the other province. And the full significance of this change in the virus is yet to be determined, and work is ongoing to characterize the impact of that. Just to finish, I couldn't finish without acknowledging a large number of collaborators. That was a truly group team effort to really sample and work around the clock. Thank you very much, and I would pass to Professor Salim Abdul-Karim.
Thank you very much, Professor De Oliveira. I want to just thank Professor De Oliveira and his team. It was a consortium that was established very early on. He came to see me about it back in February. And I want to thank the Department of Science and Innovation and the South African Medical Research Council for funding this important work. What I would like to do very briefly at this stage is I would like to share with you an understanding of what these results mean and what their potential implications are. So I'll talk about the way in which the epidemiology can be interpreted in relation to this new variant. So this is the curve we are all very familiar with. The solid black line is the 7-day moving average of the number of cases we see each day. The gray bars are the number of admissions, and the red line is the number of COVID-19 reported deaths. We know that when we saw our first case on the 5th of March, we had a rapidly growing epidemic, and then it slowed down, and we eventually saw our peak in July and August. We then went into a situation of low transmission for almost 3 months, and then in early November, we started seeing the cases rise again. And you know that Minister Mkhize announced that we are now well and truly in the second surge, which is reflected by this rapid increase in cases. If we look at what that means at a provincial level, we know in the first wave that the various provinces had the epidemic rising at different rates, and so we expected to see that again. In this time, though, the epidemic started in the Eastern Cape, and it was the first to rise. There's a whole range of reasons why that's the case. I won't go into that right now. And subsequently, we've seen a rise in cases in the Western Cape, KwaZulu-Natal, Gauteng. And what about the other provinces? If you magnify this area at the bottom and look at all of these other provinces, even though they have smaller numbers, we are now seeing a rise in cases in all provinces. In other words, our second wave is well and truly established now in all of our provinces. What are we seeing? If we just look at the Western Cape, in the light green line, that's the curve for the first wave. In the dark green line, that's the curve for the second wave. In the first wave, what we saw was the epidemic starting off in Cape Town and then spreading around to the other districts. And so we had this long, drawn out little peak, and then it came down. What we are seeing now is the rate of increase in cases is similar to the first wave, but we've seen now that the epidemic is much, much more in terms of cases than we have seen in the first wave. So the second wave has now well and truly overshot the peak that we saw in the first wave in the Western Cape. If we look at one other province for illustrative purposes, in KwaZulu-Natal, in the light orange line is the cases, the 7-day moving average of the cases in the first wave. If we look at the second wave in the dark orange line, what we are seeing is a rapid rise in the cases. Now, we wanted to also have some idea of whether this virus may be associated with an alteration in the number of deaths. And so when we look at the cases at the time when we had 4,000 cases at this point here, and we look at the recorded deaths, it was close to 12,000. If we go back to the first wave and we look at the point at which we had 4,000 cases, it was similar, roughly at around 12,000. There are some caveats to the comparison, but we wanted just to get a quick impression of whether we are seeing more or less deaths in the second wave in relation to the cases, just to get some idea of whether there's any change in the pathogenicity of the virus. And this data are very preliminary. And at this point, they certainly do not show any red flags. So what do we know about the fine balance between the virus and the host? Viruses usually evolve to become more transmissible. That's pretty clear. We see that with almost all viruses. And it's for a very simple reason that if a virus evolves to become less transmissible, then what happens is that it then wipes itself out. The ones that are more transmissible will become dominant because they transmit better. Also, viruses tend to evolve to become less severe. They become less pathogenic and less lethal. Again, for the very simple reason, if a new variant of the virus is more severe, the patients are sicker and so do not walk around and go to mass gatherings and don't spread the virus. And so a virus generally will evolve over time to become more transmissible and less severe. So we have been monitoring this virus for these changes right from the word go in March. And Professor De Oliveira and his team have been doing so. And we pretty much have got used to the idea that we're going to see 1 or 2 changes in the virus each month because it's a virus that's pretty stable. But these changes that do occur, they mostly occur in humans in response to immune pressure. And sometimes they occur when they pass through another species. For example, the original bat virus was able to infect humans when it passed through another species thought to be the pangolins. So that's the 2 ways in which the virus spreads, the virus changes its genetic structure. The SARS-CoV-2, as I've pointed out, has been relatively stable in the first wave. We know and we've recorded that we have somewhere between 30 and 40 different lineages. And most of them are derivatives of the more transmissible D612 variant, which we acquired from Europe. It's different from the original Wuhan strain because it's slightly more transmissible because of this variation. So we have always been seeing just these lineages, and we know we've had quite a large diversity. And 3 or 4 of these lineages account for about 1/3 to around 40% of all our viruses in South Africa. So we've used to the idea of high variability and different viruses spreading at the same time. The second wave, now that we're seeing it in all provinces, is showing some early signs that it is spreading faster than the first wave. It's still very early, but at this stage, the preliminary data suggest that the virus that's now dominating in the second wave is spreading faster than the first wave. It's not clear if the second wave has more or less deaths. In other words, the severity is still unclear. As I said, we would expect it to be a less severe virus, but we do not have clear evidence at this point. We certainly have not seen any red flags looking at our current death information. So we know that this is the two diagrams that really give the key message. The first is the one on the left. This diagram shows that we had all of these different strains that were routinely spreading in South Africa during our first wave and in subsequently. But we saw a few weeks ago this little yellow blip. And initially, there was no reason to be concerned. We would expect to see these kinds of variations arise. But what became quite different that we did not expect is the rapid way in which this variant, now in the yellow, this new 501v2 variant, has become dominant in South Africa, as Professor D'Oliveira has so clearly outlined. And this particular virus has 3 mutations on the receptor binding domain. That's the actual part of the virus that attaches to the human cell at the ACE2 receptor. And one of the interpretations of these changes is that it increases the affinity for the ACE2 receptor. The other 2 mutations also convey and possibly add some potential antibody escape, but at this stage, the full implications of the combination of the 3 mutations still needs to be understood in more detail. The second diagram that is concerning is this diagram, that when we look at the 501v2 variant, Professor D'Oliveira already pointed out that when you look at this 501 variant, the CT score, the CT number is lower than the other viruses that we routinely have that have been spreading during our first wave. What does that mean? It means that the amount of virus that's in the swab is higher. You have to interpret it in the inverse. A lower score means a higher amount of virus. We refer to that as the viral load. So when we're doing that swab, we're getting a lot more virus in these patients that have the 501v2 variant. So the full implications of this need to be understood, and these data are still very preliminary. We want to increase the sample size and ensure that this is a very stable estimate. But at this stage, I will just speculate the following. The first is that the higher viral load in these swabs may translate into a higher efficiency of transmission. In other words, higher transmissibility, and that fits in with the epidemiological data that I've provided. The second is that if there's higher transmissibility and higher efficiency, it may translate into a higher R0. R0 is that each person who's infected, how many other people they're going to infect. The third is that while the other viruses are still transmitting, right, because they are still in the community, they are still spreading, this virus is spreading so much faster that when we take swabs, it is the dominant variant that we see. And then the final point I'd like to speculate in terms of the meaning of this higher viral load is that this may translate eventually into a second wave that may have many more cases than the first wave. So this is not original data. I'm not presenting you data. I'm just speculating on what this may mean, that we're seeing this virus become dominant and that it's associated with a higher viral load. So let me end off with explaining what is it we do know and what is it we don't know about this variant. So we do know that it's an unusual variant, and it's unusual for a new variant to contain so many mutations. Usually you'll see a variant with just a few mutations, and particularly to see a variant with 3 mutations in the RBD, especially including the N501, which we think and has been shown in STAR, and others have shown this in the paper in Cell, that alters the attachment affinity to the ACE2. In other words, it has more affinity. It attaches better to the human cell. The 501 has been reported in other countries, including the UK, Australia, and several others. It accounts for about 2% of all the viruses that have been sequenced. There are about 250,000 sequences available. And in our country at this time, we are finding between 80 and 90% of the viruses are this 501 mutant. So we're seeing a much higher proportion than is being seen elsewhere in the world. We're seeing early signs that the new variant is spreading fast, sometimes faster than the first wave viruses, and that it is widespread. We don't yet have data from Gauteng. Those viruses are still being sequenced, including the Free State, but it probably is quite widespread given the rapidity with which it has been growing. So what is it we don't know? We don't know where it came from, and we don't know why it formed. We don't know. We found the first of this virus in Nelson Mandela Bay, but we don't know if it originated in Nelson Mandela Bay. It could have originated anywhere, and somebody could have traveled there, or it could have started spreading there after being brought in. So we don't know where it originated. What we do know is that we first found it in Nelson Mandela Bay. We have some hypotheses, and I won't go into those right now, but we are investigating that to look at trying to provide some clarity on that issue. The second thing is it more severe? Well, we don't know. It's too early to tell. Third, is it reinfecting people who got infected in the first wave? We have no information to answer that question at this time. But as you heard from Professor De Oliveira, we have 2 laboratories that are growing the virus. It's already growing and available now in the laboratories of the African Health Research Institute. And we will start doing studies to answer that question. It's not hard to answer that question. It just takes time. For example, once we've grown the virus, we will then add in convalescent serum from patients who recovered from the virus in the first wave, and to see whether it neutralizes the virus, so that we'll have some idea as to whether those who were infected in the first wave are protected from this virus in the second wave. So that's an unanswered question at this time. Will the current vaccines work against this variant? Well, this also needs to be studied. It'll take a little bit of time for us to answer this question, and it's currently being studied by a range of different groups, including CRISP, RE, NICD, and Caprice. And we can look at patients who've been vaccinated and look at their serum panels, which are available once we've got the virus growing well, to look at whether it neutralizes the virus. So all of these will be questions we will be able to answer with time, but we do not know those answers just yet. So what should we do next? I think the first is that there is reason for concern that we have a virus that seems to be spreading rapidly. But it is something we can deal with. It's a virus that's already been found in Australia. It's not exactly the same mutations, but they have the 501 mutation, and they've been able to also control it. Importantly, the same diagnostic tests, the same prevention strategies, and the same treatments work against this variant. So this is an opportunity for us to reinvigorate and to enhance our prevention measures to hold back this virus as we see it spreading rapidly through our communities. We do not need to change any of these strategies at this point. In terms of the current diagnostics are still effective. Our current strategies of social distancing, hand hygiene, symptom checking, mask wearing, all of them remain the basic strategies of prevention for this virus. Similar 501 variants are found in other countries. They do not have the same RBD changes, but they have the basic 501 variant in these countries. We need to inform key role players in the public, and we started doing that yesterday, and the public is being informed today. The data are being published in a journal. The paper is almost written, and Tulio and his team are hoping to have that submitted pretty soon. We need to urgently increase our phylogenetic screening. We need to sequence many more viruses. We need to get a sense of how this virus is spreading whereabouts throughout the country. So we need to increase our screening. It should be noted that this is not an easy thing to do. To do a full genome sequence of this virus is an expensive and time-consuming business. And then finally, we've already put in motion some studies, and we'll work with many others, and this is an open invitation to others who want to help answer these 4 questions. The virus is readily available. We can supply that to other investigators. We'll collaborate with many of our colleagues across the world, including throughout Africa. And fortunately, in terms of the actual answering the question on vaccine trials, we have several vaccine trials that are currently underway in South Africa, including, for example, the J&J vaccine. So we'll have direct clinical trial evidence as well as laboratory evidence about the impact of this virus and whether our current vaccines are still effective, which I would expect it to be. On that note, I'd like to thank my colleagues for making this important presentation, and I hope I've given you a sense of what is it we do know, what is it we don't know, and giving you some impression of what we need to be thinking about next. On that note, I'd like to hand back to Minister Mkhize.
Thank you very much, Professor Abdul Karim. Together with the team led by Professor de Oliveira, and the rest of the consortium has even been introduced. May I at this point call on my colleague, Minister Nzimande, to make his reflections on this matter. I will come in after that, and then we open up for questions. Prepared.
Kabazela, thank you very much, and thanks to Professor de Oliveira and Professor Slim Karim for the explanation that they've given. We hope this actually explains, as Professor Karim was saying, it's bad news, but at least what has also been presented relates to what needs to be done, and that going forward, we're ready to actually deal and manage this despite the threats that it poses. All I want to say, Minister Mkhize, and to all my colleagues, I'm also joined by my DG Mjwaka, who has also indicated that on our side, we are really committed to continue to support this work that is being done. Already a budget has been submitted to us, Minister Mkhize, as DSI, of about 45 million rands, and we are willing to say that we can commit right now 25 million rands for this work to be done as indicated in terms of further research and further studies that actually needs to be done on this score, so that we continue to make sure that science is there in support and in service of your department as you lead this effort to actually deal with COVID-19. We started this on the 20th of, in June 2020 with this project, and already it's beginning, as I have said, to show some progress, and there is no reason why we should not continue, as it underlines the importance of genomics in dealing with this pandemic, which also lays a very good basis, by the way, for future challenges that we may have going forward. Thank you very much, Minister.
Well, thank you very much, Minister Nzimande and the Director General, Dr. Mjwaka. Your support in this is quite critical. And may we also say thank you for the support that you have just indicated and the further commitment to ensuring that this work continues. I want to then make some comments on this matter. Before I go into the issues relating to this variant, I want to talk about this second wave. If you ask me a question, what has caused me concern on this second wave? But by the way, before I proceed, let me acknowledge that we have got our colleagues from WHO, Dr. Kalua, who's also in attendance. There's also the CEO for Africa CDC, Dr. John Kengasong, who's actually also on the on the call. And then there's also observing from the virtual platform is the WHO regional Afro region director, Dr. Mweti. Of course, she's not full-time on this because she's dealing with some family issues at this point. And I want to just acknowledge that. Now, the question, if you were to ask me about the second wave, firstly, we knew it was coming, but none of us actually expected it to come as quickly as it did. Now, there was not anything, there was no specific projection that would put, but that it came before sooner than it was expected. It did take us off in a bit of a challenge, because you recall that a few months earlier, a number of hospitals, field hospitals, had been kind of started to be dismantled. The second issue that's been of concern is that it's coming at a time when the behavior during the festive season is likely to worsen the spread of the COVID-19. It's a season for people coming together, you know, in congested areas and so on. So a whole lot of issues there. The other issue is that we had noticed some degree of complacency with the wearing of masks and the hand sanitizers and so on. And we've been picking up a number of cluster outbreaks, and that we attributed to the complacency with this. The other concern that, the fifth concern that we've got is that the second wave is increasing during this season, but we actually believe it's most likely to increase any case after the season, because you've got people coming together now, but there's been a lot of movement of people into various provinces. That movement is going to be reversed early in the year. And so it may well actually have another bump wherein the numbers are showing an increase. So these are issues that we are now looking at as we're going to be reopening in January, that this is another area of concern. Of course, the other area has been the high number of 14 to 19 years of youth who have actually tested positive in a higher number than we've actually seen before. All of these together, now you have got this new news of this mutant variant. So it does then say to us, we should be concerned about it, but it's not the reason to panic. If there's anything which we need to actually emphasize now, as Professor Abdul Karim has said, is that it's going to be important for us to emphasize on what we know works. And those are the issues of wearing of masks, using sanitizers, hand washing, and distancing. Because those will work as effectively for the COVID-19 as we have known it, and they'll work as effectively on the variant, because it's the behavior of that pandemic that we are actually targeting. So I think that if there's anything to be taken from this discussion, is that we have noticed that there's a variant, but at the same time, what we have advised should be the way to deal with it. It needs to be emphasized that we must loyally adhere to this practice of non-pharmaceutical intervention, because that is the way we'll be able to deal with it. The other aspect that I think is important is to also appeal to the media and also our colleagues in the medical and scientific community that we should focus on the facts. We have come in here to share information as being factually recorded, but we need to avoid entering into speculations and issuing unproven statements or generating panic or disinformation, because this situation can be handled in the way that COVID-19 has been handled, even though it might be a variant, but it's actually important that you can handle it, because the approaches are still the same as what we've been using dealing with COVID-19 as it had been brought to our attention. Many countries have experienced a second wave that was more severe than the first wave. So we're not different now to other countries. Many countries have gone through what we've gone through. Even in countries who have not themselves reported any mutations, we've seen that there's been an increase. So in our case, we're also seeing that that might be the pattern. So we must gear up for a stronger fight against COVID-19. Now, the next question somebody would ask, okay, what are we going to be doing now? Well, firstly, our current case management is guided by clinical manifestations of the pandemic, and this approach has still been effective irrespective of the reports of the mutation that has been identified. In other words, the same treatment that we have been using before, we're going to continue to use now. There's been no evidence to suggest that there is a need to change any of the clinical treatment. And if there would be such a situation, we'll talk about it and then we'll deal with it at that point. But right now, we will continue to treat in the way that we have been treating before. Even the fact that there's been a variant should not make us feel that there's any change. But we have also directed that our Ministerial Advisory Committee, which is the clinician subcommittee, should go into this matter. And then whenever there's going to be a need for changing the clinical treatment and patient management protocols, then they would actually report that and give us advisory when they deem it necessary. So we're watching that space. Right now, there's no need to change. There's no need to panic to think that there's some new treatment that we're going to need, or at this point to ask the question as to whether any of the treatment that has been used, is it going to be effective or not? At the moment, it has been effective even before we knew that there was a variant. So we want to keep that as a matter of reassurance to the public. Then someone else might ask the question, because we have discussed this, are we going to bring in new additional restrictions now? Lockdown 5 and lockdown what, level 3, level 4, whatever. The point is that the president has just recently announced more restrictions, which are using a differentiated approach across the country, which means that we implement different containment measures depending on the infection spread in such areas as hotspots, and also what we anticipate as social behavior during the festive season, as well as what we need to strengthen inspections and enforcement measures so that we can contain the spread of the infection. We will keep to that. We are not proposing any new restrictions that are associated with this variant. This variant, we're going to treat it as the COVID-19 that we have seen before until the scientists come with something new that makes us change something there. So we are saying we will keep to that. We're not bringing a recommendation for the Coronavirus Command Council to bring in new restrictions, as it were. What the president announced is what we're going to stick to. Until there's a new issue, we will not be changing that. In fact, as far as we're concerned, this discovery does not yet necessitate additional measures need to be taken. Then the reports, which are based on surveillance and intensive monitoring, will continue to guide our response, which is driven by science. We will declare new districts as hotspots when the situation arises and they reach the threshold, and then we continue to monitor how this increases the impact on our health services and on healthcare workers. Otherwise, whatever we have declared, if tomorrow we declare another district as a hotspot, it will be because of the criteria that we set even before we knew about the variant. And therefore, we will deal with it on that basis. So if there's 2, 3, 4, whatever number of districts that we think they are hotspots and we say so, it will be because of the pre-agreed factors that have been taken into account. We have a resurgence plan that guides us on this, so that affair again will not be affected by this variant. In response to the second wave, we've directed that all the provinces must reactivate their resurgence plans, and they've done so, and therefore they must mount an appropriate response to COVID-19, ensuring the following issues. One, the adequate human resources for health and employment of nurses and doctors and all staff that is needed so that we can cope with the pressure that we're seeing in the hospital. We also have asked them to look at reactivation of field hospital beds that had been closed and reuse those that are available, and also preparing more beds in the ICUs, which we used in the earlier upsurge, bringing in ventilators and other necessary equipment, also provision of adequate oxygen. So all of this was actually already a directive to all the provinces ahead of this announcement. So we're going on with that work. We also have said that there must be adequate psychosocial support for our staff, healthcare workers, so that they get the support. But they will still be prioritized for vaccinations against COVID-19 next year. Invariably, of course, as you have heard, the research raises a number of questions, and then we have directed that there should be support so that further investigation research should be done. For example, the point that's been raised by Professor Abdul Karim, if you have been infected before and you develop some degree of immunity, are you now vulnerable or liable to a reinfection? No one knows that, and so we will not delve into speculation on that matter. There's no information about it. When the information comes, we'll talk about it. Then the other question that's been raised is about the effectiveness of the vaccines. The vaccines that have been that are being researched, as far as we know, they are effective in dealing with this issue, and therefore, unless there's a new research that shows that there's a problem, we'll continue with the program of vaccines when the vaccines come next year. So people shouldn't be worried that, okay, why are you continuing with this vaccine because there's now a variant? We'll continue anyway, because firstly, the first COVID is still there, but secondly, we will want to get evidence that there is a problem with the vaccines, and so that is in the hands of the scientists. So before there's any change, there is no new action that we will deal with it as such. But I want to take this opportunity to speak to our youth. Last week, I made an announcement that we entered the second wave, and that's mostly young people who are testing positive in recent weeks, and it continues to be the case. Our clinicians have also warned us that things have changed, and that younger, previously healthy people are now becoming very sick. Despite all these warnings, in the past couple of weeks, we continue to see recent videos on social media of youth partying in large numbers, even some displaying kids in games, and also not wearing masks, and some clearly intoxicated. And we've had to actually ask that those who are part of some of these rage parties need to go for tests, and we found quite a number of people who are already affected and are infected as a result of that. Our youth are not wearing masks and are clearly intoxicated, that they throw away caution to the wind and don't care about the rules of the disaster. It cannot be that our youth must only adhere to life-saving measures only after being policed to do so. We therefore call on parents and caregivers to understand, and our youth to understand, that it's now not just a matter of thinking about others, but even about yourself. And therefore, you yourself are equally at risk of dying of COVID-19. I think it's important that the enjoyment must never actually be a reason why we must lose another life. And that is a point that I think our youth need to be able to understand. And all of this is important because we've dealt with some of the challenges such as AIDS and so on, where when we had mothers and grandmothers burying their children. I think it's important for us to say there's enough knowledge now for us to be able to behave in such a way that we can save everyone and save ourselves. And therefore, our message out of this variant is that the situation can't be contained. It depends on how well we stick to the basics that have been indicated, that of using masks and distancing and hand washing and sanitizers. That remains our fundamental issue. So the information that you have got today, we'll continue to update in the interest of transparency and keeping the public informed, so that all of us are aware where the situation is. And when there's a change, we'll actually indicate what is new that is needed. At this point, I'd like to hold it and then request that you ask the questions, and then the team here is much bigger than the two professors who have presented. They will take us, they will give us the responses. Thank you very much.
Thank you very much, Honorable Minister Nzimande, and Prof. Salim Abdul Karim and Prof. De Oliveira. Thank you very much for taking the nation through these developments. I will now move on to the questions, Minister, and to the consortium from the Genomics Group, and to all scientists, members of the MEC that are on the call now. I do have questions from both the chat group and from my group. So I will start with the questions coming from my group, and we'll move to the questions coming from the chat group. Colleagues, we will answer all the questions, but if you have been covered, please don't repeat the same question. I will start with probably questions that are probably more for the scientists, and then we'll move on to questions that perhaps the ministers can respond to. The first question is from Femida at ITV News. As the mutations occur, will they affect the human cell further? And does it alter symptoms in any way? Femida Kasim. I apologize, I don't think she's with ITV News anymore. I then have a question from Sophie Mukwena from SABC for an editor. Have you been able to trace or track patient 0 of this virus? I assume she means this variant in South Africa, in Nelson Mandela to be specific. I have a question from Elzabeth Brits who asks, have you seen any clinical effects at all? From Elzabeth Brits at Freya Vetblatt. I have a question from Nadia Honeyball, who from Netfact24, who has asked, has any new or different symptoms been detected in people contracting the mutated variant, and how reliable are the current COVID tests in the light of this new variant? And then from Zolega Kodasha from SABC, other than the rapid spread of the new variant, are you aware how it affects those who may be infected? Do we see the same symptoms as reflected since the outbreak earlier this year? Does the mutation in the virus mean that it is more aggressive? I'll stop there for now from this particular cohort of questions, Minister, and the scientific team. Thank you.
Thank you very much to all of those who raised these questions. There are 3 of us who will attempt to answer these questions. It's Professor De Oliveira, Professor Lessels, and myself. I will ask Professor De Oliveira to start and answer the questions he would like to, and then we'll deal with the remainder. Professor De Oliveira.
Thank you, Professor Abdul Karim. Yeah. So the first question, it is about the virus mutating. Yeah. So that's what virus do. Yeah. And we know that very well from HIV, for example. It develops sometimes resistance to antiretrovirals. Yeah. So it is common the virus mutate, and normally we have a fixed mutation rate across the world, around 2 mutations per month. Yeah. So what is not so common, it is accumulating a lot of mutations very quick in the receptors and in the main binding site. Yeah. And we are also seeing the same ones across the world, especially in the UK. Yeah, it's also one large transmission cluster with the same variant. Yeah. So the answer is to that there is reason for concern, as Professor Abdul Karim highlight, but it's also a reason to understand better this variant, which we call 501v2, is the second big variant spreading across the world with that mutation. But to tell you that there is no concern, especially on the diagnostics, they were not made to that region of the virus. So our diagnostic worked perfectly. To be honest, all the samples that we got was from a positive diagnostic on the 3 markers. So we have no concern on that area. That was another question. Yeah. In relationship with patient 0, no, it is very difficult, if not impossible, to identify the patient 0. And you notice that we could still not identify the source of the zoonotic transmission of SARS-CoV-2 to humans. Yeah. And honestly, that's neither important at the moment. The most important thing is to try to curb the transmission of this lineage, yeah, as we have done in the first wave. The objective normally is to try to decrease transmission and extinguish a lineage. Yeah, one lineage with a similar mutation in Australia in that position have been extinguished. So it is possible to basically stop the transmission of this lineage. But as our minister mentioned, yeah, we will have to take much more serious our prevention efforts, and also to try to really decrease the, not to have a chance to this virus to stay spreading very, very far. Yeah. Thank you.
Thank you very much, Professor de Oliveira. Professor Lessels, do you want to comment on the clinical issues?
Yeah, so I think there are a few questions all linked about what do we understand about the clinical effects? Could this have different symptoms or be more aggressive and have a different disease course? And the reality is we don't know the answer to a lot of that, but we will, now that we've detected this new virus lineage, we'll be working with speed to try and understand whether it does have any clinical impact. It's highly unlikely that it would have any different clinical symptoms. There's no reason to believe that, and that wouldn't fit with our understanding. But one of our concerns is, could there be a difference in the progression of the disease? And as one of the questions said, a more aggressive disease course. It's challenging to understand that, because as we go into the second wave and we see this rapid rise in cases, clinicians are again faced with seeing a lot of patients in the hospitals and a lot of patients who are very sick. And so getting a sense of whether they're seeing a different disease course is challenging, and it needs us to look at the data very carefully and tease out some of the information in that to really understand. And as I say, we'll be working at speed to do that and to get a better understanding.
Very much, Richard. I'll just add 2 points, if I might. The first is that this information was presented to the Ministerial Advisory Committee, and several of the clinicians there are now initiating research that will help us answer the question on whether there are any variations in clinical features. I would be surprised if there are, but we need to do empiric research to ask that question and answer it. So we don't know the answer for sure at this time, but the evidence is being, steps have already been initiated to start looking at that question. The second is, I want to just explain that what we are talking about is a new variant. It's not a new strain, because in SARS-CoV-2, we don't yet have a nomenclature to define the different strains of the virus. So we don't talk about strains, we talk about lineages, or we talk about variants. So I want to just request that you don't use the word strain, because there is no such thing as different strains per se, because we haven't defined that. So just use the word variant. It is scientifically the most accurate way to describe this new variation in the virus that we are seeing. I'll stop there. Over to you, Lwazi.
Thank you very much, Professor Karim. I will continue to stay with technical / scientific / clinical questions. I have a question from Sbu Ngalwa from Newsroom Africa. Is there any information regarding the recovery period of those infected with the new strain? So as a country, should we review the isolation period from 14 to 10 days? Will the isolation period
I'm sorry, Lwazi, can I just make a quick request? We have CEO of Africa CDC, Dr. John Nkengasong. Would like to ask him to make a comment, because he's got another urgent pressing matter that he needs to attend to. Thank you very much for joining us, Dr. Nkengasong. If you could just give us a comment, we'll go back to the question and answer session. Thank you.
Thank you. I mean, let me first of all really congratulate the team for this important discovery of this new variant. And I followed the presentation from the start to now, and I'm very impressed with the way it used genomics to tracking this epidemic. This is exactly what we should be doing, applying a combination of standard epidemiologic tools with genomic sequencing to understand the evolution of this virus. Clearly, there's still a lot of work to be done ahead, and of us to understand this, the clinical and outcome of this variant and what it means for patient management, as the minister rightly stated. So I'm very pleased to say that we are ready to work with you very closely to continue to understand the dynamics and evolution of this variant. And we look forward as Africa CDC to working with you in this respect. Thank you.
Thank you very much, Dr. Nkengasong, and certainly your presence here is really very important, and so we will continue the collaboration. Thank you very much, and thanks for the time to come and share with us your thoughts. Thank you. Dr. Lwazimanzi, please proceed. Thank you.
Thank you, Minister. Yes, indeed, the field of applied genomics is extremely exciting. I will just repeat Bungalwa's question. Is there any information regarding the recovery period? And should we be reviewing the recovery days? I'm just going to be first selecting some of the more clinical questions. From News 24, Jenna Fister, is the new strain similar to the UK's VUI 2020-12/01, or is it the same thing? Right, it's Bisoma Kwetla from SABC in full view. If there are new genetic variants as a natural process that viruses undergo, can one be infected with more than one? And if so, what is the effect of that? Right, now I'm going to move now to the chat box and see what clinical questions we may have there. So there is one from Dr. David Tumare. The variant that is dominant, is it more virulent, hence causing more severe COVID-19? A question for Prof. Karim specifically. We've heard indications from seroprevalence tests now underway in Soweto that 25% of the population may have been infected during the first wave, possibly more. If true, what could that say about SA's outbreak and about potentially high levels of immunity? Then a question from Criselda. Has the virus's behavior changed? If so, what are the changes? A mutated virus sounds instinctively scary, but to mutate and change is what viruses do. So what is the challenge now? I think the why was supposed to be a what. Another question from Criselda. Can the current ARVs be considered as a preventative measure? Your take on the use of remdesivir to prevent patients from being chronic whilst we seek further clarity. A question from Inso at BDFM. Is the emergence of the new variant the reason? I'm sorry, I'm going to wait for this question a little bit later. Apologies. Right, we can stop there for now. Thank you.
Thank you very much, Dr. Manzi. I think there are a few questions on the variant itself, and I think it's important that we deal with the issue of how similar or different it is from the reported UK, where they talked about the new variant under investigation. I'll ask Professor De Oliveira to address that issue, and then I will address most of the others together with Professor Lessels. Professor De Oliveira.
Okay, thank you. So in the UK, they also identify a variant or a lineage, which they call the variant under investigation. That's what VUI mean, and they call VUI 2020 because they are really trying to investigate that. Yeah, there is quite a few similarities between these two lineages. Yeah. So what are the similarities? The similarities is that they have also multiple changes on the spike proteins. Yeah, in the UK they have 6 changes in the spike protein. Yeah, plus a deletion that could easily count as 1 or 2 changes. Yeah, and we have 8 changes in the spike protein. Yeah. They also have a similar number of mutations, yeah, which it means around 20, 22. Our one also have around 22. In addition to that, the other similarity is that they share a common position. That's the 501Y, and that's why we have decided to call our lineage 501YV2, the second major variant that has been detected in the past few weeks. Out of that, the rest of the mutations, they are different. So we are similar on the number, and also on the number, both at the spike and also in the genome, and one key mutation that's associated with binding of the receptor, the 501. But out of that, these lineages, they emerge very differently. Yeah, they would fall very far apart on the evolutionary history of the virus. Yeah, so in the same way that they went to the parliament and to the public to explain that and put this lineage under investigation, very serious investigation, to try to stop and understand more. That's exactly what we are doing in South Africa. And we work both together with the researchers in the UK as part of the WHO, the World Health Organization Evolution Group. Yeah. And both of these data, both of South Africa and the UK, they are open available. That's one effort that what we're trying to do as a scientific community is to share data and samples very quick so we can answer a lot of the questions that is coming from these new variants. Yeah.
Thank you very much, Professor Dover. Professor Lessels, you want to comment, and then I'll deal with the remaining questions.
Yeah, so I think there was a clinical question around the recovery period and whether we think there would be any difference in the recovery period and whether that requires rethinking the isolation period. And I think there's nothing to make us believe that recovery from an illness would be different, and certainly no indication at the moment to consider changing the isolation period. There was a question about, as there's these different strains circulating, different lineages circulating, can you be infected by more than one? And we don't think you can be infected by more than one at the same time. Our concern is more about that the antibodies you generate after an infection may not be able to recognize a new virus if it has certain changes in its structure. And that's what we're now trying to understand with these genetic changes that we see here, whether they are enough to escape the antibody response and to cause a reinfection. There were similar questions, I think we answered them, about whether this is more virulent, causing more severe disease. We don't know, and we're working at speed to try and understand that from the clinical information we have in the country. And there was a question around ARVs and remdesivir. I think we know in terms of the antiretrovirals and their use, there are clinical trials ongoing, and there's no evidence yet to support their use in routine clinical practice. And the remdesivir, again, unfortunately, we saw disappointing results from a clinical trial that showed in the context of hospitalized patients, it had no clinical effect. And so it's currently not recommended for use. And there's no reason to believe with this lineage of the virus that there would be any different response to remdesivir. So I've finished there. Thank you.
Thank you very much, Professor Lessels. I'll just quickly answer the remaining questions. Just to add on to remdesivir, remdesivir acts at a different stage in the way in which the virus replicates. So it's not impacted by these variations that we are seeing in the genome. So remdesivir, if it has any benefits, it shouldn't be any different for this variant than it would for any other variant. On the issue of the seroprevalence of antibodies, we yet do not know whether the past infections and the antibodies generated by past infections will neutralize this new variant. I don't anticipate that there will be a difference, but we do not have any evidence one way or the other. At this stage, it remains an open question, one that's already studies underway to address. Is this virus more virulent? At this stage, we do not think it's more virulent, but we need more clinical studies to confirm that. And those studies, as I mentioned, are currently in planning. And then finally, the issue around whether we need to change our isolation period and recovery, there is no indication that that needs to change. That will remain as per our current guidelines. We see no reason to change that based on the new strain. I'll hand back to you, Dr. Mansi.
Thank you, Prof. Karim. The next set of questions will probably more be for the Minister. However, there are some technical questions that have slipped through, so please, if the scientific community can come through on that one. Minister, in the light of what has been presented, it becomes clear that prevention messaging is more critical than ever before. What plans are we making to ramp up the messaging that physical distancing, mask wearing, and hand washing is critical? And this is from Ansel Tom at the Daily Maverick. Ansel continues to ask, the NICD has been at the forefront of the COVID response. What is being done to support them in the light of the work that has to be done to see if the vaccines in the pipeline will work? Minister, if I may just have an opportunity to just move on to the other group, which had more questions for Minister. Right. So we have now a question from Mariam Issa at Finweek. Given that the new variants of the virus are dominant in SA and spreading so rapidly, might the country be seen to have a responsibility to close its borders to prevent its spread elsewhere in the world? And she continues to ask, or rather, is there any possibility, in your opinion, that other countries may not want to accept travelers from South Africa? A question from Lemza Farmer. If you don't have enough data on whether the COVID-19 vaccine will work on the new variant, will government proceed with the procurement of the vaccine? Tanya Faber from Sunday Times. Among the non-pharmaceutical interventions, should the Minister of Health not also be placing a big emphasis on ventilation? Okay, here's a technical question from Craig Jenkinson. Could the second wave involving the new variant actually serve as a type of natural inoculation if it is proven to be less lethal? And is the alleged slow movement by government in ordering a vaccine for SA linked to questions about the efficacy in treating the new variant? I'll stop there, Minister, and then after these questions, we will move on to some more questions that are in the group. Thank you, Minister.
Thank you very much. The one question relates to what support to be given to the NICD. We work with the NICD as a very important institute that deals with the monitoring and the testing, the detection of the pandemic, in particular the COVID-19. And therefore, we continuously work together to look at what new additions need to be done in investing into their institution so that it can become more effective. There's quite a lot that we're there to do, bringing in additional systems to improve the data capturing, to the processing of data and the reorganization of data, the ensuring that we've got the best possible data reports that we get from NICD, so that we can use that to inform the public and also to guide the response of government. So they remain a very important part of the department. We have emphasized now on the communication that the issues of communication should not just be seen as the Department of Health, but that from presidency to various ministers, premiers to the provinces, and also to ward councillors, and in particularly in the areas of the hotspots, we're actually gone to the level of ensuring that there's loud hailing. When the numbers increase, we emphasize on loud hailing, and people in churches and traditional leaders all participating in sending the message across, including various sectors of society. So those, for example, who are in the retail space, we actually have to emphasize that they have to send the message and the reinforcement of the message of non-pharmaceutical interventions. So we do believe that it's important to deal with it, not only for government, but also not for central government only, but for all levels and layers of government to deal with that. The question that was raised earlier, there's a question you dealt with and didn't complete. That was about what was the issue and the delay on the COVAX commitment. The decision by cabinet was taken quite a while back, and when the Minister of Finance was asked the question, he responded that this matter has been kind of dealt with, because technically the issue was whether we are participating or not, and that was the decision was taken by cabinet that we are. And so everything else was just administrative and technical processing of the issue. So the delay has really been more at that level. It starts really with a question of understanding. This was the requirement from COVAX, that there are certain guarantees that needed to be done, and therefore the format that they used for guarantees and what Treasury was using was not aligned, and it took a while to actually try and clear those issues. And I can just say at this point that I've signed the guarantees now as the Minister of Health. They've been also countersigned by Gavi, and we expect that the money will be deposited in the next 2 or 3 days, so that that matter is actually closed. But the delay had nothing to do with the principle of whether we're participating in it or not. It had more to do with the just dealing with the systems internally, so that they're aligned. Right now, everything is aligned, and we're happy that the process is moving on. The other question came from Marianne Issa that relates to the question of do we foresee travelers from South Africa being rejected or closing the borders? Well, we're not going to be closing the borders. In our earlier discussion, we spoke about the fact that there's a need for us to have a research that looks into the impact on the migration, particularly migrant workers within the region, so that we can see what steps need to be taken at that level. But there's no closure of borders is not envisaged. And also the issue of travelers, we don't anticipate that there should be an issue. In the first instance, this is not a different virus. It's the same virus with a variant, and therefore we're dealing with COVID-19 with a slight mutation. The second issue is that not enough is known at this point to actually support any idea of this South African travelers being rejected by any country. But thirdly, every country has had its own variant, and therefore you've heard about the UK has got its own variant. You've heard about the same variant coming from Australia, and that action was done, and in fact it was contained in that situation. As things stand now, the current variant has not reflected any need or any suggestion that it requires different treatment, different testing, different forms of management. And on that basis, therefore, we don't believe that there's any possibility that there should be a rejection of travelers. But research has to be done. And what is most encouraging to us is the fact that the research is collaboration right across different countries. So whatever we know, the other countries will know. So there won't be anything new. This is the same virus. I'm not sure if we could have done something to the virus that will make it behave in such a way that every other country doesn't see any different problem. So I expect that there might be various changes that will happen here and there in different countries. It's for the scientists to be able to indicate the total sum of all the impacts of all those changes. Then the question of emphasizing on ventilation, I think is a good point that we need to emphasize on that. The fact that the person has asked, the question has been asked, it does mean that we need to emphasize, because if it was felt that there was adequate emphasis, and for sure the issue wouldn't have arisen. So I think it's a point to us to say we must understand that there might well be a need for emphasizing at that level. And then the question of the slow movement by government on vaccines. Well, I wouldn't say that it's slow movement. We know we're part of COVAX, and COVAX is actually carrying over 187 countries in the whole world. They have got the buying power that is bigger than any country, and therefore in terms of the size. And as a result, therefore, we believe that they're doing everything to expedite this process of vaccine acquisition. A number of other initiatives, there's no time to talk about them now, that we actually believe South Africa will be on time to receive the vaccines. and therefore we don't believe that the government has been slow in it, but we think that the nature of the problem is so varied that, you will have seen, I think at the moment, 2 countries have indicated that they will be starting vaccination, US, I think the UK, and there'll be a few other countries, but obviously the resource pool of all these countries is not quite necessarily the same, and so you might find that there'll be differences in the phasing of how we are able to do that. We're still calling for equity in the distribution of vaccines. We're also calling for this equity in such a way that you can't have one country completely vaccinating and then there's a whole continent that is left out. So this is some work that we're working on. There are lots of initiatives that we're working on in this regard. If I can just hold it at that, maybe we might want to conclude the questions. I think we should try and round up at this point. Thank you.
Yes, Minister, I think let's indeed round up. Thank you very much. I think maybe we'll just take 1 or 2 more questions from the chat, and then we will thank the colleagues who have sent us questions in the group. If they've not been covered, I will just get back to them offline. There's a question from Dr. Mark Sondrap, who says, it's a technical question, how does this differ from the annual antigenic shift and drift of the H and N components of the influenza virus, for example? We have a question from N. Shongwe, who asks, could the recent congregation of high school learners writing matric exams relate to the emergence of more frequency in the 14 to 19-year age, and hence selecting out of this new type? I'm reading the question as it is written. Minister, I think we can, a related question, please can you confirm whether younger people seem to be more severely affected by the new variant? And I think looking at all the other questions, Minister, we can hold it there. Thank you.
Thanks, Dr. Manzi. Minister, would you like me to address these and leave the ones for you?
Yes, please proceed. In fact, I think all of them are for you.
Okay, thank you. I'll address them directly, and I'll then hand over to Professors De Oliveira and Lessels to complete it. So there were really the 4 questions. The first is, would this faster spreading virus provide us with a level of herd immunity that could emerge as a result of the spread? And the answer to that question is that I think the whole approach of trying to aim to achieve herd immunity with natural infection has been discredited. And what we do know is that even with a rapidly spreading virus of this nature, it is very unlikely that we can reach levels of coverage that would go anywhere close to herd immunity. So I think that that's not really a practical solution, not achievable. The second question is, how does this differ from the antigenic shift and drift we see in influenza? And I think I'll ask Professor De Oliveira to answer that. I was going to address it in terms of flu, but I'll leave that to him. The question relating to high school students and younger people. I think it's quite important to appreciate that even though this virus may have a higher efficiency of transmission, it is still fundamentally dependent on the risk factors that we've seen with the other viruses. In other words, it's the same risk factors. It's the movement of people. It's not having the prevention measures in place. It's interacting with many people, going into crowded places without good ventilation. So I think all of those are the same factors. And what we're seeing in this particular second wave is that those factors, combined with perhaps a higher efficiency of transmission, is resulting in a faster spread. In other words, it's a confluence of factors that are coming together. But fundamentally, this virus, no matter how efficient it is, cannot spread if we are not interacting with others in a situation that enables the virus to spread. And so our traditional prevention measures are really critical and would really stop this. So there's no evidence at this point that this virus is any different in its clinical manifestations or in the age group that it's impacting. Remember, a point that perhaps I didn't make clearly enough, that when our second wave was first beginning, we had the same usual lineages of the virus. This particular variant only emerged as the second wave was establishing itself. So we already had the other viruses that were spreading. And when we look at the transmissions that we had with the other strains, they were also in the younger age group. So it's not specific to this particular variant. It is a function of who is getting infected by virtue of their risk factors. I'll ask Professor Lessels to comment, and then I'll give Professor Dorver the last question relating to how this differs from flu strains. Professor Lessels, do you want to add anything?
I don't think I have anything to add to what you've just said, so I'll leave to Tulio to answer the difficult question.
Thank you. Professor Dorver.
Thank you. Yeah. Honestly, the answer is not very difficult. Yeah. This virus, the SARS-CoV-2 and influenza, are very different viruses. Yeah. And the antigenic shift that normally happen in influenza is when two viruses tend to mix together and exchange small pieces of the genome, because influenza has a segmented genome. This virus has one genome, is not in segments. So wouldn't the process of antigenic shift that happen in influenza wouldn't be the same process that add slightly mutations that create new variants in SARS-CoV-2. So the only similarity between these two viruses is that they are respiratory virus. So it's another process that's driving the evolution of the virus, and to the best of our knowledge, wouldn't be associated with antigenic shift as it is seen in influenza. Yeah, thank you, Professor Karim.
Thank you very much. I think that sums it up from us, and I'll hand back to you, Minister.
Thank you very much, Professor Abdul Karim, Dr. Lessels, and Professor De Oliveira and the team for all the work, and thanks to Minister Nzimande and the Director General, and of course to the Deputy Minister, Dr. Phahla. Can I just, if you can just oblige me just 2 minutes, I have a request to deal with this issue in vernacular in a matter of a few minutes. Oqala nje sifisa ukumemezela ukuthi njengoba sihlanganise lo mhlangano besizobika ukuthi kochwepheshe esinabo besayensi sebethe uma becwaninga bathola ukuthi igciwane le-COVID-19 seliqale ukuguquka ngaphakathi ngohlaka olwakhiwe ngalo, lokho okuyinto efuna ukuthi ibhekisiswe ngoba uma liguquka lisenokwenza ukuthi bese liziphatha ngendlela engafani naleli gciwane besilokhu sililapha sigijimisana nalo kunyaka wonke. Kodwa-ke njengoba kukhonjwa lokuguquka akusho ukuthi sekuyigciwane elisha, kusho ukuthi kuseyilona lelo gciwane. Ngamanye amazwi sizoqhubeka nokulelapha njengoba kade sihlale senza ngale COVID-19. Into engifuna ukudlula kuyona yokuthi sinayo ingxaki ngalesi wombe sesibili se-COVID-19 njengoba siqalile nje kakhulu besisibika eMpumalanga Koloni nasentshonalanga Koloni, sesiweleleke manje nakwezinye izifundazwe kakhulukazi KwaZulu Natal nase-Gauteng. Kodwa kuyacaca ukuthi nakwezinye izifundazwe kuya ngokwenyuka amanani abantu abanaleli gciwane. Into esihluphayo ukuthi le gciwane lisheshe labuya kakhulu ngokushesha kakhulu ngesikhathi esasilindele, besingalindele sokufika ngalesikhathi elifike ngaso. Manje ke lifika ngesikhathi lapho sonke sesiphumulile sihleli kuma-holiday. Leyo nto leyo yenza ukuthi indlela esiziphatha ngayo yenza ukuthi kube lula ukuthi leli gciwane liqhubeleke phambili. Ikona-ke nje kubalulekile ukuthi uma silibuka silichaze emphakathini ukuthi lithanda ukusihlupha njengamanje sibona abantu abasha kakhulu kuyibona abanaleli gciwane kodwa futhi uma nasezibhedlela abelaphayo bayasho ukuthi abantu abasha akufani nakuqala bebengabi baningi abagulayo kodwa namhlanje sibathola bebaningi abafikayo abanye babo kodwa kuyacaca ukuthi abasakusebenzisi naloko kwakuzi ifonyo sasithe akusetshenziswe abanye babo bangena kakhulu ophuzweni basebenze ngendlela yenza ukuthi ekugcineni kube lula ukuthi babe nokuthelelana. So ngaleyo ndlela ke sibona ukuthi uma sekuthiwa liyaqala ukuguquka leli gciwane lizozenza libe yingozi uma ngabe singezuqaphela. Kodwa into ebalulekile ke namhlanje ukuthi sizoqhubeka sililaphe ngale ndlela ebesilapha ngalo ingakabi khona ukuguquka kwalo kodwa okukhulu kukona ukuthi ukusebenzisa ama-mask kusabalulekile, ukugeza izandla nokusebenzisa ama-sanitizer kusabalulekile, nokuthi abantu bangahlangani babe isiminyaminya, nokuthi uma behlele endlini kuvulwa amafasitela bangaminyani ukuze kube khona umoya ozoshaya ozokwenza ukuthi lingandi kakhulu leli gciwane. Imkhona-ke imibuzo eminingi elokhu ivela yokuthi kusho ukuthi-ke abantu abanaleli gciwane bengenwe yileli gciwane ekuqaleni i-COVID-19 namhlanje mase khona lolu guquko isengabuyela nikubona leli gciwane libaphinde. Kodwa-ke ngoba ucwaningo akaphumeli obala lapho sisathatha ngokuthi isimo sisazofana nakuqala. Okwesibili akukho uguquko esinalo esizolwenza ngokulashwa kwabantu ngoba sisazoqhubeka silaphe njengakuqala. Ngakho kodokotela nabochwepheshe sibacelela ukuthi abahlale beqaphile ukuthi uma kukhona ushintsho olufuneka ukuba lwenzeke ukuthi kulashwe ngendlela ehlukile basichazele ukuthi naku uhlelo oselifuneka silusebenza. Kubalulekile futhi ukuthi njengoba sithathe sifuna kube khona ukugoma gonyelo leli gciwane le-COVID kusho ukuthi nangonyaka ozayo uma ifika le migomo sisazoqhubeka nayo ngendlela ebesivele sihlele ukuthi sizokwenza ngayo. Sizoqinisa kakhulu kulabo abasebenzi kwezempilo kulabo futhi ababuthakathaka kwenzela ukuthi leli gciwane noma liyabuya lingalimazi kakhulu abantu ngendlela okwenzeke ngayo. Ikhona-ke imibuzo emisha ethi uma sekuthiwa leli gciwane siqala ukuguquka futhi lona eselibhebhetheka kakhulu kusukela kulezi ifundo esezibaliwe ukuthi lokho kusho ukuthi sesofuna kube khona uhlelo olusha yini lokuvalwa kokwenziwa kwezinto emphakathini njengoba kade kwenziwa. Sithi-ke cha asizushintsha lapho kulezimemezelo ezibekwe umongameli. Umongameli ushilo ukuthi kunendawo lapho kufanele siqinisekise kakhulu ukuthi abantu mabehlangene abaminyani kakhulu ukuthi basebenzise into zokugeza izandla nokuthi basebenzise ama-mask. Lokho sofuna siqhubeke nako kuyo yonke indawo. Kuney'ndawo lapho siyama-beach awavalwe, kwezinye iy'ndawo siyama-beach siwaqaphile ukuthi awazi ukuba nenkinga yabantu abayisiminyaminya kakhulu. Sithe imihlangano eminingi kakhulukazi engaphakathi kwezindlu ukuthi leyo mhlangano leyo kufanele abantu banciphe babe yikhulu. Uma kungaphandle kushaya umoya kufanele baqaqane bathi ukuhlukana benzela ukuthi igciwane lingangeni kakhulu kubona. So zonke lezo zinhlelo lezo sizoqhubeka nazo asisuguquka asishintsha kodwa sizoba phezulu kokuthi uma singakwenza kakhulu konke lokho kuthiwa sikwazi ukulivikela leli gciwane singakwazi ukulinqoba kwalona leli ngoba selike labonakala eNgilandi libonakele ngendlela elenzeke ngayo alikabi libi kakhulu khona kodwa lase-Australia balenze laba khona base baliqeda. Ngakho-ke nathi singakwazi ukulwa naleli siliqede. Kubalulekile futhi usazi ukuthi njengoba sesathe gozololo ngamaholide uma sesibuyele emsebenzini sesibuyele emakhaya sesibuyele lapho esivakashele khona ukuqala kwenyanga ingozi inkulu yokuleli gciwane singaliqhubela phambili. Ngakho-ke silindele ukuthi mhlawumbe imali enyuka manje uma singakwazi sizame ukuthi senze yonke into ukulivika ukuthi lingaqhubeki ngoba isekhona ingozi ukuthi uma kuqala unyaka futhi sazokwenyuka kakhulu. Siyafisa ukuthi nibe namaholide amahle kodwa futhi sazi ukuthi ukuziphatha kwethu kona kuzokwenza umehluko noma uma ngabe sibuyela emuva sizofaka abantu abaningi engxakini yokuba baphathwe izifo noma sizobe sibuyela sonke siphilile. Masiziphatheni-ke ngendlela sibambisane ukuze silinqobe leli gciwane. Siyabonga. Thank you very much to all the colleagues. Let me then ask Dr. Lwazi if you would be in a position to close at this point. Thank you very much to the members of the media and thanks to all South Africans for being with us during this discussion. We'll continue to share news as they come along, but we believe it's important for us to remain accountable and transparent to the public of South Africa. Thank you very much to all the researchers and all the work that's been done. Siyabonga.
Thank you very much, Kabazela. Thank you very much to Professor Salim Abdul Karim. Thank you very much to Professor D'Oliveira and to Prof. Richard Lessels, and to all of the esteemed scientists that have put in this incredible work, and we can bring this media briefing to a close. Thank you so much.